Hello everyone, I'm Nirosha Varghese from Bocconi University and welcome to this last presentation of the IQC final workshop. My PhD focuses on topics related to economic shocks, well-being and adaptation, and today I'll be presenting one of the projects under this broad theme, which is hospital closure and AMA outcomes using evidence from Italy. To give an institutional context of hospital closures in Italy, the government introduced a range of austerity measures as a response to the 2008 recession. And these cost containment strategies were also extended to the healthcare sector. One of the schemes, for example, was Piano di Rientra, which was enacted in 2008. This scheme was basically a financial recovery plan, which was aimed at restructuring and targeting those cost factors that led to budget deficits in the healthcare sector at the regional level. And they had like 6 areas of cost reduction in the scheme, and one of them was based on or focused on hospitals. For example, hospital network reorganization or incentivizing dehospitalization. Another area was workforce reorganization in the healthcare sector, where they basically freezed all turnover and stopped all hiring. One important thing to note about the scheme is that the scheme was implemented in a very staggered manner and only in those regions that were administratively incapable of dealing with the budget deficit. And the scheme resulted in workforce cuts, shortage of hospital beds, and hospital closures, which in turn led to poor health outcomes. And this aligns with what the literature usually says, that austerity interventions that are targeted at healthcare or health sector is directly related to poor health outcomes, especially mortality due to certain causes that is very sensitive to spending variations such as cardiovascular diseases. And this leads us to hospital closures in Italy. What the literature says is that hospital closures can have both negative and positive implications on patient welfare. And looking at the negative implications, it could reduce patient access to care or cause treatment delays. And this usually happens through two channels, either increased travel time to get to the next hospital when a hospital closes down, or congestion or overcrowding in the remaining hospitals. This is very crucial for example, cardiovascular diseases, because time is a crucial event for the success of the treatment. For example, if a patient gets a cardiac arrest, the patient has to be taken to the hospital within 5 minutes, or else the brain might suffer irreversible damages. Looking at the positive implications, so these closing hospitals are characterized or known as underperforming or underutilized. So the patients that used to go to the old hospitals are now reallocated to better performing hospitals, which means that their health outcomes might also improve. Or it could be that the remaining hospitals might face a huge inflow of patients, and they might respond to this demand by improving their operational efficiency, which in turn might improve the patient outcomes. So overall, the net effect of hospital closures is unknown. So the two main objectives of a study is, one, to look at the effect of hospital closures on patient outcomes, specifically in hospital mortality, 30-day readmission rate, and the length of stay. And this is done at both the individual and the municipality level. And two, to explore the two main mechanisms, which is increased travel time and bed utilization rate, which is a proxy for congestion or overcrowding. Moving on to the empirical strategy. In a study, we use a staggered difference in difference, or in other words, difference in difference at multiple time periods, to examine the changes in patient outcomes before and after a closure. And to look at the possible mechanisms, we use a two-stage approach, where in the first stage, we use the difference in difference estimator as an instrumental variable for the travel time and bed utilization rate. And in the second stage, our health outcomes, including mortality, they are regressed on the predicted values from the first stage. And if our parallel trend assumption is satisfied, we could say that our difference in difference estimate is the causal effect of hospital closures on patient outcomes. Now to briefly look at some terminologies that we use in our study and in our empirical strategy. We say that a hospital is closed based on two alternative definitions. One is the 90% and the other is the zero count. So based on the 90%, we say that a hospital is closed if the year-to-year admissions in a hospital reduced by 90% or less and stays constant. And accordingly, we get 52 hospital closures in Italy in a study period from 2008 to 2015. Or we could say that a hospital is closed if the admissions in a year in that hospital falls to zero and stays like that. This is a more conservative approach, and accordingly, we get 36 hospital closures. And a closure year is considered as the year which is prior to the closure. And here we focus on home hospital closure. So each municipality or each individual has one home hospital, and the municipality is told to be treated if that home hospital closes. So in our study, we say that a home hospital is the model hospital to which most of the residents of the municipality were admitted, and a municipality is treated if at least one home hospital in that municipality closes down. This is just a spatial distribution of the treated municipalities. Although we have a few concentrated pockets here and there, overall we could see that the treated units are spread out throughout the country. Moving on to the data, so we initially start with a data set that has the universe of AMI patients between 2008 and 15. And after merging it with several external data sets, we have a final data set that has information at individual, hospital, and municipality level, including municipality to municipality travel times. So overall, at the individual level, we have around 0.8 million observations, and at the municipality level, we have around 8,000 municipalities. Moving on to the results. So what we find is that at the individual level, a home hospital closure increases the probability of in-hospital deaths by around 0.8%, reduces 30-day hospital readmission by 2.2%, and increases the length of stay by 0.3 days. The results at the municipality level is similar qualitatively, but it's more larger in magnitude and also statistically significant, stronger in significance. Also, we add some leads and lags to the treatment, first of all, to check the parallel trend assumptions and to see if this negative effect of hospital closures fades over time or not. What we find is that the effect of hospital closures are persistent over time, so adaptation to this negative event will take a long time. Looking at the mechanisms at the individual level for the first stage, we find that a hospital closure increases the average travel time by around 3 minutes to the next hospital, and also increases the bed utilization rate by around 12 patients per coronary care unit. Looking at the second stage, what we find is that an increase in travel time and also bed utilization rate worsens patient outcomes. Specifically, it increases in-hospital mortality, reduces 30-day readmission, and increases length of stay. At the municipality level, again, results are similar and stronger and larger in magnitude. So to summarize, we find negative and persistent effects of hospital closures on patient outcomes. And this basically happens through two channels: increased travel time and overcrowding in remaining hospitals. Given this negative effect of closures, especially for patients admitted to emergency services, one question to the policy makers and the administrators is if there's a need to bail out inefficient hospitals. So one study that conducted different simulations of hospital closure in several scenarios found that bailing out inefficient hospitals in areas with fewer hospital choices reduces or minimizes the adverse effect of hospital closure on mortality. So this is basically selective bailing out or selective closures depending on the characteristics of the hospital or the market. Our study also is useful to hospital administrators to understand the implications of a hospital closure and how to revise their management strategies accordingly. Our study also supports some kind of monitoring or regulations at the regional or the provincial level to eliminate sources of overcrowding or congestion, which we show to have a negative effect on patient outcomes. Finally, in Italy, the health spending per capita is around 15% lower than the EU average as of 2017. In addition to this, the current pandemic-induced economic situation kind of increases the risk of hospital closures, overall, which points to the relevance of a study and of findings in the present scenario. Thank you.